pointer if you need it.
Okay, thank you. Good morning, everyone. Thank you for being here. I appreciate the opportunity to come talk about something that I really enjoy discussing and have a particular interest in. So thank you for being here. So we're going to talk about pre-exposure prophylaxis in general. I will discuss some other key elements of HIV prevention. It's, of course, not my intention to make you experts at pre-exposure prophylaxis because I myself am not, but just to go over the important points regarding the updates and the recommendations, and then if you're going to use it, how you should use it, and what population and what the guidelines are. So our objectives are listed. We're going to talk about some key strategies in HIV prevention and then review the data that supports and challenges the use of pre-exposure prophylaxis. And that's specifically and only for the sexual transmission of HIV, okay? And then we'll discuss the recommendations released by the CDC, their actual interim recommendations for the use of pre-exposure prophylaxis and HIV prevention. So just to sort of get a taste of where we are currently in the HIV epidemic, just one slide on worldwide, you can see that we are doing an excellent job in treating people, getting them to live longer. Thus, we have the increase in the number of people living with HIV, as indicated in these light blue bars here, a little well above 33 million at this point. And then, as you can see, the number of deaths due to AIDS is this red line and sort of have peaked in the early 2000s that has subsequently fallen. So the part that's concerning still is that the number of people newly infected with HIV, so the HIV incidence peaked in the 1990s and has fallen, but has sort of taken a steady, straight angle here lately. So in the United States, this sort of mimics the previous slide worldwide where we see an increase in the number of people living with HIV and AIDS. That number is estimated to be about 1.2 million at this point. However, you see sort of a stagnant line here in terms of new HIV infections. So the scale of this graph is sort of large, so bringing it down to more recent years on a smaller scale with these definitive numbers, we can see that between 2006 and 2009, the HIV number of new patients with infections stayed pretty constant. The number for 2010 was about 47,100 and some. So not making sort of very much difference in those numbers here lately. So as we think about the stages of engagement in HIV care, so there's a broad range of stages. So if you look at the number of those infected with HIV, this estimate is a little bit behind. Like I said, it's more like 1.2 million at this point. But this indicates 1.1 million infected. And we estimate that about a quarter or 25% of people are unaware of their HIV diagnosis. So 75% of people are diagnosed with HIV. A portion of those are linked to care. A portion of those linked to care retain in care, meaning they maintain consistent visits with the HIV provider. A portion of the ones that are retained in care need antiretroviral therapy according to the guidelines or the previous guidelines. And then of those that need antiretroviral therapy, only some of those are on antiretroviral therapy. And then we get all the way down here to those who are on antiretrovirals. The proportion of those who are adherent or have undetectable viral loads is only about 20% of this number of HIV-infected individuals in the United States. So you can think about the possibility of transmission among all of these groups in between there. This is just indicative of the spread of the cases of HIV in the United States. And so the purple color or shading is sort of the worst in the United States, and we're here in North Carolina and have a pretty high caseload here. So I'm pretty sure we're all aware that the primary mode of transmission for HIV is sexual contact, namely men who have sex with men, but also heterosexual contact. So this is where we're focusing a lot of the prevention efforts, and thus comes the conversation about pre-exposure prophylaxis in these groups. So the CDC paired with some mathematical models and thinking about where we are with HIV, where are we going over the next 10 years? And they came up with this, a model that looked at 5 different strategies to estimate where we would be in both prevalence and incidence for HIV infection in the United States. So the first stable transmission rate line, and they based all of this data off of the 2006 information that we had at the time. So the HIV incidence in 2006 was 55,400 new infections per year. Prevalence was 1.1 million. So they based this data off of that and said, well, over the next 10 years, if the stable transmission rate, which would be 5 cases per 100,000, stayed constant, how many new cases of HIV, or how many total cases of HIV would we have by that time? So you see it's between 1.5 and 1.6 million. If we kept a stable incidence, meaning about 55,000 new cases per year, which we've already decreased from that number, but we have a little bit less in terms of the total number of persons infected. And then if we just looked at only the slope of transmission between 2000 and 2006, that gives us a little bit more leverage as well. Still over 1.3 million people living with HIV in the United States in 10 years. So the interesting part was that they modeled these intensified intervention scenarios that would be implemented either over 5 years or 10 years. And these intensified interventions included rapid expansion of HIV testing, behavior changes interventions with persons living with HIV or considered at high risk for HIV, and then increased resources for surveillance, research capacity building, and other public health activities. So that's a lot of factors that they put into estimating where we could, how far we could get with the money that we put into HIV prevention. So if we look just at prevalence, we'll see that if we use the 10-year expansion of resources and intervention, that we can further drop the prevalence. And then over 5 years, remember that at 5 years is where the intervention would stop. So over 5 years, we would still be in better shape than the 10-year mark, but that decrease in prevalence would be sustained. And then this is incidence. So looking at the same thing, but I just wanted to focus on the new cases of HIV in these intensified intervention groups. So again, over 10 years, sort of had that slow downward in the slope. And in the 5-year intervention, you have sort of that rapid downward in slope, and then just the maintenance of the decreased incidence over time. But ultimately, in 10 years, ending up sort of at about the same place. And these case-based scenarios estimated that you would decrease prevalence of HIV at about 30 to 38% over 10 years. So in all of this, HIV prevention is key. And so there's many forms of prevention. So it's been wonderful actually to see government sort of input on HIV prevention that's been increasing lately. Secretary of State Hillary Clinton gave a wonderful speech at our AIDS 2012 conference that was held in Washington, D.C. this year. It's the first time it was held there in 22 years because we had a ban on allowing people with HIV infection to enter our country, and that ban was lifted, and subsequently we were able to have that conference there. But anyway, she talked about the PEPFAR, which is the President's Emergency Plan for AIDS Relief, and how they're planning to implement $157 million new dollars in HIV initiatives, and that would be global initiatives. So their primary focus is going to be on mother-to-child transmission of HIV, where they're investing $80 million into this effort globally. They're putting about $40 million in circumcision efforts, and that's going to be concentrated mostly in South Africa. And then putting money also into all these other efforts. And again, this is not domestically necessarily, but it's will affect the HIV epidemic worldwide. So putting money into the test and treat movement, implementation research, meaning that we're going to implement many of the intervention strategies that we're coming up with, expansion of services for people living with HIV and at risk for HIV, and support of civil groups that are on the ground doing work for HIV. So their detailed plan is supposed to be revealed on World AIDS Day this December. And so domestically, we also have the Office of National AIDS Prevention that have released the National AIDS Strategy. And their number one objective for the National AIDS Strategy that's come out is to reduce new cases of HIV. So we do have some plans for that. So let's look at the different prevention opportunities we have in HIV. So I like this slide because it gives us sort of the full scale of many different ways where we can intervene in HIV infection. So we have unexposed persons, persons who are HIV negative, who are at risk or may not be at risk, but these interventions are largely behavioral and structural. So giving people the education that they need to know what they can do to prevent their risk of acquisition of HIV, providing circumcision, which is a structural intervention, condoms, and STD treatment and education, okay? And so then we move to those that are exposed, and this is just before, during, or after sex acts. And then also other types of exposure like needle sticks and things like that. So in terms of precoital and coital exposure, we have investigated vaccines, which have been promising, but unfortunately we have nothing sort of on the rise in terms of that would be coming to our prevention efforts in the near future. Microbicides have been investigated, and microbicides are simply local suppositories that would usually be gels that can be applied to the vagina or the anus to prevent sexual transmission of HIV. And I'll discuss one of those studies, but you know, we sort of have a lot of questions whether those will be able to work in the long term and then under what circumstances. So then we have pre-exposure and post-exposure prophylaxis. So we do have guidelines on the use of post-exposure prophylaxis, both in sexual assaults and workplace exposures. But here's where we're going to be talking about today, pre-exposure prophylaxis, and what that means and how we'll be able to use it in our prevention efforts. And so here's another large component of our HIV prevention that has been increased over the past few years when we talk about treatment of a person with HIV in order to prevent the transmission of HIV to a negative partner. And I have an example. So the biggest sort of news that came out of treatment as prevention came out in 2010, was published in New England Journal of Medicine, and it was considered the breakthrough of the year, according to Science magazine. And it essentially was a study that was conducted in many sites, but mostly in Africa, that showed that prevention of HIV could be effective if you treated the HIV positive partner. It demonstrated a 96% reduction in HIV transmission to the HIV negative partner. This was a huge study, a lot of excitement around that, and sort of now we're focusing on where do we go from here now that we have this information. And sort of also sort of off topic just a tad bit, but the recommendations for HIV treatment, the DHHS has recently updated the guidelines in March 2012 that indicate we should now be treating everyone who's HIV positive. So there's no longer any indication that we should be looking for CD4 count or viral load, but we should consider treatment immediately for every person that's HIV positive. And that sort of goes back to this study and the public health implications of treatment of HIV positive persons to prevent transmission to others, okay? So get into pre-exposure prophylaxis. So the FDA approved Truvada for the prevention of HIV among individuals at high risk of HIV infection and who may engage in sexual activity with HIV-infected partners. This was announced in July of this year. And Truvada, I have some more pictures of the pill, but it's a blue pill, so don't run away, don't be scared. The only reason I'm showing this slide, this is the life cycle of HIV. And I just wanted to show you that we use our antiretrovirals in a manner that we can interrupt the life cycle of HIV. And each of these oranges sort of things show at what points we're able to interrupt the life cycle. We use 3 medications for HIV therapy, 3 medications at all times, okay? And we do that because the studies have shown that that's the best efficacy with the least side effects and the long-term outcomes, okay? Using less than that makes it, you have an increased risk for mutations and resistance to the medications that we use. So when we talk about Truvada, it's a combination of 2 medications, tenofovir and emtricitabine. It's a nucleoside reverse transcriptase inhibitor, and it's a once daily regimen. It is not a pill to treat HIV. If a person is HIV infected, you do not use Truvada alone. This is only approved by itself for the use of pre-exposure prophylaxis. So just making sure that that's clear. So it's renally eliminated. It can cause acute renal failure. It can cause lactic acidosis, specifically when combined with other medications that can do so as well. Hepatomegaly with steatosis. And has also been demonstrated, mostly because it's a tenofovir component, to decrease bone mineral density. This medication treats hepatitis B infection. This alone can treat hepatitis B infection. And that becomes important when we think about who we're going to use it in for pre-exposure prophylaxis. Okay? So again, I don't want you to be experts, but I do want to give you a summary of the literature that we have to support pre-exposure prophylaxis. There's been 6 major studies that were done, and I'll sort of review the key points of all of them here. So CAPRISA 04 was the first study that looked only at microbicides in women, okay? It did not look at oral pills. So it looked at almost 900 women in South Africa, and they used the tenofovir gel versus placebo. And when we look at adherence, which is going to be very important in all of these studies, about 38% reported adherence above 80%. And it was shown to have a 39% reduction in the transmission of HIV. Okay? The main safety concern was diarrhea. When this study came out, it was very big news in HIV prevention. However, we've really been unable to duplicate these effects in other studies. So it hasn't sort of reached scale, and we aren't really recommending microbicide therapy, okay? Or microbicides for pre-exposure prophylaxis. So the next sort of big study here is IPREX. This is the only study that has been done in the United States. The remainder of the studies have all been done mostly in Africa. So in IPREX, we looked at men who have sex with men, and then there were transgendered men in this group as well. There were about 2,500 people, and they looked at daily oral Truvada versus placebo. They measure adherence by self-report. And in terms of efficacy, the overall efficacy estimate was about a 44% reduction in HIV transmission. If the participants reported greater than 50% adherence, then their efficacy was about a 50% reduction in HIV transmission. If they reported greater than 90% adherence, then that was estimated to be about 73% reduction in HIV transmission. One thing that the IPREX study did that was novel and sort of duplicated in the next studies was that they chose a population of persons to look at and measure tenofovir levels. So they said, okay, you're telling me that you're taking this pill every day. Well, let's draw some blood to confirm that we can detect the level of drug in your serum. And when they did that, of course, there was a correlation between persons that had tenofovir levels in their drugs and the reduction in transmission of HIV. So their estimates indicated that if you took just 2 doses per week of the Truvada, that you reduce your chances of acquiring HIV by 76%. If you took 4 doses per week, you reduce your chance by 96%. And if you took it consistently daily without fail, you reduce your chance of HIV acquisition by 99%. So that's pretty significant. The next study was Partners PrEP. So this one was done in Kenya and Uganda. So they had serodiscordant couples, and that means that one person in the couple was HIV positive and the other person was negative. And they looked at tenofovir versus Truvada versus placebo. So adherence, they measured pill count, so pill bottles. And so they said that about 90% of the dispensed doses were taken. Well, they were either taken or they were thrown away or they were given to a friend, but they were gone, okay? So they estimated that in the tenofovir group, there was a 67% reduction in HIV acquisition. In the Truvada group, it was about 75%. In this study, they actually ended up taking they ended up taking the placebo group out because it was shown that it had no effect, and they re-randomized the persons on tenofovir and Truvada into re-randomized those people into those groups, and they are following for long-term safety and efficacy. And the main concerns in this group was nausea and diarrhea. And I'm sorry, I forgot to mention in the PrEP study that the safety concerns were that they found people that took the Truvada had more reports of nausea, headache, decreased kidney function, and bone mineral density, as we would expect sometimes with tenofovir use. And so the last 3 studies were all studies in heterosexuals. The tenofovir 2 study was 1,200 heterosexual men and women in Botswana, and they did Truvada daily versus placebo. Again, adherence, it was reported to be about 80%, and they had a 62% reduction in HIV transmission. And then the same sort of safety concerns that we have with tenofovir use were found in that group. PrEP studied heterosexual women in particular in Africa, and they took Truvada daily versus placebo. So this study was stopped early because futility was demonstrated. If for adherence, reported adherence was greater than 90%. But again, when they went back and measured tenofovir levels in the participants, they found that adherence was less than 40%. So the main safety concerns in this study was nausea, vomiting, and increased ALT. And then the most recent study that is still ongoing is the VOICE study, looking at heterosexual women. And it's had 5 arms initially: tenofovir, which is the one component of Truvada, Truvada itself versus placebo, all oral pills, and they had 2 arms of microbicides, so tenofovir gel versus placebo. Adherence is not yet reported, but they stopped the tenofovir gel and the tenofovir oral pill arms early for futility. So those persons, again, were randomized to the other arms of the group, and we'll be expecting the data from this study in, they estimate about January to March 2013. So when we look at these PrEP studies, so we have differences in the studies in the mode of PrEP. So you have microbicides or intravaginal or intraanal microbicides. And then there's a wide variability in adherence. But the key is that adherence is very important to have the goal and the outcome that you're looking for. So we're looking more at, in these studies of adherence, making sure that we can have a backup way to prove that the patients are being reliable when they say they're taking their medication, not relying on self-report and not relying on pill counts. So actually doing drug levels. And not just drug levels in the serum, but also doing drug levels in vaginal and anal areas too, and tissue. And so the questions that remain that the CDC has tried to answer for us on an interim basis is: who do we give PrEP to? What is a protocol for PrEP, and how do we use it? And then there are further studies ongoing about what other agents we can use for PrEP. And those other agents would be perhaps some HIV medications that we have already in use, developing agents that are long-term. So just like you can sort of get a depot shot, maybe you can go in and get a once-monthly shot of a medication that'll prevent HIV. So those studies are coming up. So the CDC, again, released the MMWR on August 10th that will provide interim guidance for clinicians considering the use of pre-exposure prophylaxis for the prevention of HIV infection in heterosexually active adults. So they're trying to be very specific here. Their target is heterosexuals at very high risk for HIV acquisition, and they try to define that as people who are uninfected, whose regular sex partners are known to have HIV infection. And we sort of have extrapolated this into persons who are have many sexual partners who are in groups where there is a high prevalence of HIV infection, regardless of whether or not they know or for certain that their partners are HIV infected. So these are the guidelines, and these are sort of the key things that you should know and be aware of when you're considering giving PrEP to a patient. So before you initiate PrEP, you have to document that they're HIV negative, right? It only makes sense. We said that Truvada does not treat HIV in and of itself. It only is approved for use for pre-exposure prophylaxis. So you have to be sure that the person is not HIV positive. If you're suspicious that they could be positive or have an acute infection, meaning that they have recently acquired HIV, then you should do a test for that, and that would be an HIV viral load to ensure that they're HIV negative. There has not been much data, and again, some of the safety data is coming down the road, but in using Truvada in pregnancy and ensuring that there are no long-term effects. So you want to, if there's a female patient, determine what family planning they have, if they're on birth control, what their goals are for having children in the future. And then, of course, confirm that the patient is at risk, and they define it as ongoing and very high risk. And if they have a partner who is known to be HIV infected and that partner is not in care, it is your obligation to link their partner to care. So it's an extension of care from the person that you're actually going to be taking care of to their partner. So labs, again, we said tenofovir is cleared through the kidney. It has to be renally dosed. So you can't give Truvada. It's a fixed dose combination if their creatinine clearance is less than 50. So you want to be sure that it's 60 or above before you initiate therapy. And again, you have to screen for hepatitis B. The danger with giving Truvada in a patient who has hepatitis B is when they say, I'm no longer in this relationship with this HIV positive person. I don't think I need to be on this pre-exposure prophylaxis anymore. If you withdraw the Truvada, it can lead to a fatal flare in their hepatitis. And then, of course, screen for other sexually transmitted infections. Perform a pregnancy test. So when you're ready to start, you've done all of those things, and you're ready to start PrEP, you prescribe Truvada. It's 1 tablet daily. It's a fixed dose again, 300 and 200. Prescribe no more than 90 days. So 3 months is the max, because you'll have to have that person come in regularly, and that's every 3 months. And that's a big commitment for most people. And as a part of the prescription, you have to provide risk reduction counseling. So you have to discuss with them how important adherence is, that if they don't take the pill, they're basically negating the effect of the potential effect of taking it. Have to provide education on other STDs, provide condoms. And you'll see that you have to follow up every 2 to 3 months. And at those visits, you have to repeat the HIV test. If they've acquired HIV between the last time that you saw them, of course, you're going to have to stop the Truvada and sort of refer them to us, and we'll go down the path of treating them for HIV. Every 3 months, do a pregnancy test on women, document and encourage their adherence, and then assess their risk behaviors. And this is an ongoing talk that you have to keep having with the patient regarding their risk reduction, giving them condoms and other things that they'll need. And then screen for STIs if they're symptomatic. The creatinine clearance has to be checked at the first visit at 30 days, and then it's recommended for, not 30 days, excuse me, at 3 months, and then every 6 months after that. So every 6 months is interesting. They say, you know, you can screen for STI symptoms every 3 months, but every 6 months you have to test for other STDs, even if they have no symptoms of them. Even if they have no symptoms, every 6 months, test for STDs. That would be syphilis testing, gonorrhea, chlamydia, and MSM. What we've been discussing is doing other sites of testing for gonorrhea, or pharyngeal and anal tests for gonorrhea. And you have to measure creatinine clearance, like I said. So what about discontinuation of PrEP? How do you approach that? Of course, if the patient says that they feel that they're no longer at risk, or there's too many side effects or what have you, then that's fine. For safety concerns, and of course for any suspicion of HIV infection, you have to repeat the testing, and if positive, you want to do a genotype. The genotype is a test for resistance. If they've you would want to know if they developed resistance to Truvada, the components of Truvada, because they were on this at the time where they acquired HIV, and link them to care. So if they're hepatitis B positive, then technically you should continue treatment for hepatitis B, even if you're not going to continue treatment for pre-exposure prophylaxis. And then if they're pregnant, of course, referral to prenatal care. So it's a lot of work, huh? So what are the challenges for PrEP? Adherence is the biggest challenge. Just as the studies have demonstrated, if they don't take it, then they're putting themselves at continued risk. And as providers on a day-to-day basis, we aren't able to check tenofovir levels in the blood. So we do have to rely on the patient reports of adherence. And what about acute HIV infection? That's a huge concern. For patients that were enrolled in these studies, I didn't mention before, but some of the patients that were enrolled at the time where they were acutely infected with HIV, so their antibody tests were negative, several of those patients did develop resistance mutation and aren't able to use Truvada as a component of their regimen to treat HIV. And then there's this sort of theoretical increase in risky behaviors. One thing that I've sort of heard about recently is that in some MSM communities, when they're engaging in risky behaviors, taking drugs, they'll include Truvada as a part of their party in order to decrease their risk of HIV acquisition. So does that, is that going to be an issue? Are people going to be sharing? Are they just going to get a prescription so they can take to these parties? So those are things we have to think about. So overall, HIV prevention obviously has many, many components, and I've really tried to just focus on one today, but you'll hear more and more about the others, but it's a big and challenging ordeal. So if we're thinking about HIV prevention and the use of PrEP, and you have any discomfort with it, then I would encourage you to give us a call, give me a call, and we can go through the recommendations again and make sure that we're on the right path to doing that. And that's it. I have one little slide here. On the wall, you can see my college diploma, my medical school credentials, and my HIV test results. So I'm not encouraging us to be in full disclosure with our patients, but I think that HIV should be a topic of conversation with all of our patients. Okay, that's it.